Yeah, so I was going to say feel free to interrupt, but I guess we're not going to do that today. So we'll wait till the end for questions. But if there are questions that come through the chat and you feel fit to, that it's a good time to ask me, please feel free to interrupt me. And you know, it's lit is a big topic, and to cover it all in an hour, I don't know if I can do it full justice, but we'll do our best here. So I would start with saying that, you know, having built a laser ablation program here at Henry Ford Hospital really relies on the strength of the team. You know, some of the faces here actually might be familiar to Dr. Enam. Dr. Ewing, for instance, has been at Henry Ford for, you know, I think almost 40 years, and is one of my main research collaborators, working on extending the applicability of laser ablation for to enhance delivery of chemotherapy. So these are my disclosures, and you know, I don't think we need to belabor the point, but glioblastomas are bad, and average survival is poor, 15 to 18 months. And although it is both local and diffuse disease, the majority of recurrences are going to happen in the local area around the resection cavity, most of them within 4 centimeters of the original lesion. And so although it's diffuse disease where there are tumor cells basically spread almost throughout the brain, local control is still important and has a bearing on overall survival and progression-free survival. So if we're talking about the relative pros and cons of the surgical treatments that are traditionally available for glioblastoma, these are the following. So, you know, craniotomy is still the gold standard for, especially for large tumors. It has the benefit of getting a lot of tissue, so you eliminate the problem of sampling error. You get immediate cytoreduction and immediate relief of mass effect. On the con side, it is invasive, and there's a length of stay. Here in the US, patients will typically stay in the hospital for an uncomplicated craniotomy for about 4 days. As opposed to that is the stereotactic biopsy, which is certainly less invasive. Hospital stays have been, you know, or more generally overnight. And actually during COVID, some of these patients we were just sending home directly from the recovery unit. But because you're only getting a small bit of tissue, there's an issue of sampling error. And then there's also the issue of no immediate cytoreduction, and then also no relief of mass effect. So what is LIT? So LIT is a combination of time exposed to temperature to induce cell death. So when we look at the cell behavior and its exposure to temperature above 60 degrees Celsius, you get immediate cell death. And most of the ablation, when we talk about LIT, happens in this zone between 44 and 59 degrees, where it's a time-dependent kill, where, for instance, at between 50 to 60 degrees, it'll take up to a minute to induce cell death. And then at 43 degrees, it takes about 10 minutes. So below 43 degrees, there's no permanent cell damage. So the way LIT works is that, at least in the US, there are predominantly two competing systems, although there are newer systems that are coming onto the market, where you insert a laser fiber stereotactically into the brain, into the center of the mass that you're trying to ablate. There's two different systems. This is the Visualase system on the upper right, the Monterra system in the lower right. And there are slight differences in the laser wavelength. For instance, the Visualase is 980 nanometers and the Monterra is 1064 nanometers. Both of them are in the near infrared zone. Because of that, it's felt that there's perhaps slight differences in the way that the ablation happens. Generally speaking, with Visualase, you tend to get faster heating. It is a saline-cooled catheter, and that's what controls the propagation of heat. And whereas Monterra uses carbon dioxide impregnated which flows through the catheter itself. And so you tend to get lower heating, but perhaps greater control. And also because you're able to heat for a longer period of time, you're able to create a larger lesion. So if we're looking at potential advantages for the patient using LIT, is that you can perform a surgical intervention where you achieve immediate cytoreduction in a minimally invasive fashion compared to an open craniotomy. Most patients will have a relatively short hospital stay, usually just overnight, similar to a stereotactic biopsy. The incisions are small, about 1 centimeter. And in general, because the relatively less invasive nature of it, the rate of readmittance or complications is relatively low. And perhaps, maybe not as important, but still important to some of these patients is that there is improved cosmesis because, you're only talking about a small incision, 1 centimeter, as opposed to a large craniotomy incision. So, but the disadvantages are significant, and that's, I guess, why I have them in large fonts. You don't get any relief of mass effect, and in fact, because of the edema that occurs after the ablation, the mass effect will tend to get worse. The ablation zone itself will double in volume within the first 24 hours of the ablation. So it does have implications for patients, especially who have not had a prior craniotomy and have no room to swell into. There is the concomitant sampling error issue because you're doing a stereotactic biopsy and that you're only getting small bits of tissue. And then there's a cost issue. So when we first started doing them at Henry Ford Hospital, and we weren't sure if we were actually going to make, if it was going to be sustainable, if we were going to make money off the procedure. Now, obviously, the financial perspective is going to vary from country to country, from state to state, from even from one hospital system to the next. But generally speaking, the disposables are quite expensive, roughly $15,000 per catheter. Although, this room doesn't cost that much to produce. That's just what they charge us. So it's depending on the financial reimbursement climate in your particular area, it may or may not be sustainable. So I'm going to be talking about mainly tumor conditions today, although one of the main indications for LIT is actually epilepsy. And I think actually in terms of where we have moved the needle most in terms of treatment is actually in the treatment of mesotemporal epilepsy. And for instance, like I see Dr. Pabani's on the call at Emory, they do many laser ablations for epilepsy, for mesotemporal sclerosis. And in speaking with, for instance, with Dr. Bob Gross over there, if I'm understanding him correctly, for a dominant-sided, left-sided mesotemporal sclerosis, he feels that the laser ablation is the treatment of choice these days rather than a amygdala hippocampectomy. One thing, again, to consider is that if you're doing a laser ablation, especially a large one, it can cause significant brain swelling up to 2 times the pretreatment size of the ablation zone itself. And then surrounding it, the ablation zone will also increase. The edema will also increase. So this is just a closer up picture of the 2 different laser catheters. And this is actually pretty true to life, how they actually look. And we've gotten you can get some pretty striking ablations. So this is a person, for instance, a patient with a recurrent glioblastoma in the mesial right temporal lobe. He underwent a prior craniotomy. You can actually see a portion of the resection cavity here. And this is a lesion that could be resected, but he was somewhat elderly and wasn't eager to undergo another craniotomy. And what was striking about this ablation, this is actually one that was relatively early on in our experience, is that you can see that the ablation zone actually conforms very well to the cistern. And so we were able to ablate right up to the edge of the temporal lobe without invading into the brainstem. And so the patient remained neurologically intact after this ablation. This is another one of our striking cases.
Ian, sorry. So yeah. Hey, good morning. So in that previous case, there's definitely looks like some ablation of the uncus as well. Was that by design, by choice, or is that something that was more of an effect of a overspilling of the heat?
I think it was actually perhaps somewhat unintentional, but I think actually it sort of goes to in these cases. I think we really do try to go for maximal ablation. And so in this particular area, I would sort of feel comfortable going super maximal. And so that perhaps wasn't entirely intentional, although I don't think it was a detrimental effect of the ablation. Yeah.
Did you put your probe all the way into the uncus, or did you probably put it in the center, in the epicenter of the tumor itself? But do you think? So
the tumor. So the way the laser ablation heat propagates is that it propagates for about, depending on which system you use, but it propagates about 7 to 8 millimeters beyond the tip of the laser fiber. So in this case, I probably would have put the laser fiber right about here. Okay. So I was probably aiming to try to get this spot right here, and I put the laser fiber probably right there, and then it caused the heat to go more anteriorly.
That was beautiful. Yeah. Okay. Thank you.
Sure. This is another one of our early cases. Again, sort of proving to us the attractiveness of this procedure. This is a patient who had a prior anaplastic astrocytoma who had imaging evidence of a recurrence. So again, this is a very eminently surgically resectable lesion. And I think that actually has implications for some of the stuff I'll be talking about later on. But he's also understandably reluctant to undergo another surgery. And so we did a laser ablation. I think what was striking about this procedure was that we were able to get a complete ablation of the tumor while, and the heat respected the sulcus here. And this is actually the motor strip here. So the patient had a prior resection in the motor strip. So he had some pre-existing weakness in the lower extremity, but as a result of the ablation, he did not incur any additional weakness from the procedure. So as we talk about what happens with the relative advantage of laser ablation, it kind of threads that needle in between, so to speak, craniotomy and stereotactic biopsy, where you get an immediate cell reduction similar to what you can get with a craniotomy through less invasive means. However, it still has this problem of sampling error and this mass effect problem. So in fact, like I said, not only does it not make the mass effect better, it actually makes it worse. And if you're trying to, in terms of actually workflow, generally speaking, when we try to ablate a tumor, you can stack fibers, but what we're usually going to do is we're going to try to stack it along the long axis of the tumor. So we, again, keeping in mind the size of the ablation that you can create, which, for instance, for this Visualize technology, you can get about 2 centimeters. You can get a cylinder that's about 2 centimeters in diameter. And so what you can do is you can do sequential ablations. And so, for instance, in this case, there's an ablation here, you pull it back, do another ablation, and then you get a roughly cylindrical shaped laser ablation. The technique for putting these laser fibers in is pretty similar to that of a stereotactic biopsy. This is actually using the Brainlab system to do it, but this is actually, again, one of our early cases. We've since moved on to using the ROSA robot to placing our laser fibers because of its improved accuracy. But there's many different ways to skin a cat. Some of the busiest laser ablation surgeons out there are using things like the Vertec arm from Medtronic. Some people use ClearPoint. I think they use a lot of ClearPoint at Emory, for instance. But like I said, many ways to skin a cat. So the laser ablation fiber itself is quite small. So what this picture actually shows here is the cooling sheath that surrounds the laser fiber. The cooling catheter measures about 1.6 millimeters, and the laser fiber itself is about 0.6 millimeters and sits inside this cooling sheath. And so that is implanted through a bolt, which actually holds the laser fiber in place. And then after that, this is a close-up picture of that. And then we move the patient to our MRI scanner. After that, all of the ablation happens in real time in the intraoperative MRI, or in an MRI. You don't have to have an intraoperative MRI. In fact, most centers will use a diagnostic or interventional magnet. So most of the time, the ablation takes place over a few minutes. The heating happens quite quickly, and we watch in real time with MR thermometry. So what you see here is basically the heat map that's generated during the during the intraoperative MRI. And the computer will calculate a time exposed to temperature. And then what you get is a damage map on this lower right, estimating the amount of cell death that has occurred. With this also, you can get, whether it's Monteris or Visualize, you can also monitor other areas, the temperature, and in particular, if you're worried about specific areas, you can put temperature limits on those areas so that the system will automatically shut off if it gets exposed to those temperatures. So, and what you get is, and I'm sorry this didn't come through very well, what you get is a very sharp transition zone. Typically, the zone between cell death and surrounding normal brain is a centimeter or less. This one over here on the left is actually a picture of a radiosurgery, RF lesion that was created, where the transition zone is considerably broader. So again, the big thing that I want to stress here, and I think, is that is this increase of mass effect that can happen with laser ablation. So a lot of times when we're looking at a prospective case for a laser ablation, we're not just looking at can it be ablated? It's more like, what is the consequence of it being ablated? Like, will the patient run into problems with mass effect? And there are some studies out there that have shown that, generally speaking, if you get above the mid-teens in terms of volume, that patients tend to have more problems with mass effect. So this is actually this is another one of our earlier cases. It's not one that I don't think I would necessarily attempt these days because it looks just too big for a laser ablation. But this is actually a fairly striking example. This is a patient who had a left thalamic glioblastoma, actually treated by Dr. Kalkanis with the laser ablation, and we performed the ablation. It seemed to get pretty well to the margin, and what we saw over time was a gradual involution of that enhancing margin over time. Now, I think, frankly, we didn't really know what we were doing at this point, and we got kind of lucky there. But this was a pretty good response to the lit therapy. This picture on the bottom right is about 6 months into treatment. And again, so we treat a variety of conditions here at Henry Ford. I think we're over 200 cases now treated with laser ablation between mainly myself and Dr. Robin, who is a Keels co-resident. And a couple of case examples that I think were particularly striking for us before I get into the data. It's also useful for brain metastases. This is a patient who had actually a nurse, she worked at Henry Ford, had metastatic ovarian stromal cell carcinoma, and had this lesion initially manifesting as weakness in the right hand, for which she underwent radiosurgery. And after an initial sort of response to treatment, it then got larger again. And this was actually the first case that we treated of a lesion within the motor strip. And I actually did this awake. And I think, actually, I don't remember which resident was in the OR with me, but I had him actually sitting in the MRI scanner, having the patient squeeze his hand while we were doing the ablation. And what happened, and we got a nice ablation of basically a gross total ablation of the contrast enhancing lesion. And this is what sort of a typical appearance about 2 weeks after laser ablation, where the ablation zone actually gets bigger. And then gradually over time, it involuted. And so the patient did actually, it was both a positive example in the sense that we were able to get a good long-term result, but also an illustrative example in the sense that patient about 3 to 4 days after surgery began to get quite severe weakness involving her right side, which persisted for several months, but then eventually recovered such that she got back to her neurological baseline. I think that actually has bearing for how the behavior of these tumors over time also it will sort of predict what you're treating, which is one of the issues with laser ablation, particularly in the metastatic brain met setting. This is actually another case of radiation necrosis. This is a patient with metastatic melanoma who initially had radiosurgery for this left parietal metastasis. It got bigger about 8 months after treatment, and so then we did a laser ablation of it. And we did a relatively aggressive ablation, sort of even beyond the contrast enhancing margin. Patient in this case did not incur any deficits, including speech. And again, what we saw over time was gradual involution of the ablation zone. He's actually still alive. He's about 9 years out of treatment now, never having had a recurrence in the brain. And again, because this turned out to be radiation necrosis, I think that is why, because as we'll see later on, if it's recurrent disease, those tend to recur after laser ablation, after any surgery, frankly.
In the cases in which you are suspecting that there will be radiation necrosis, I'm guessing you usually let them run through the whole gamut of medical treatment, including steroids and retinoids and whatnot, before you attempt laser.
Yes.
Is that correct?
Yeah. So I would say that with the advent of laser ablation treatments, we are more aggressive with surgical treatment of these tumors, because in the past, if the only treatment available was an open resection, we're quite resistant to doing that. There is data that, so we will generally do medical treatment first, like steroids and that kind of stuff. But I don't before I offer a laser ablation, I need at least 2 scans showing growth of the lesion. But I don't know that. So what we don't do these days is that we don't exhaust all medical treatments prior to going to surgery. Like we don't, for instance, do short course of Avastin anymore prior to LIT because, basically, if we're trying to, what the data shows actually is retrospective data, but what the data shows is that LIT is actually in some ways superior to best medical treatment for radiation necrosis in terms of control of the lesion, and then also in terms of steroid reduction or freedom from steroids.
Now, the cases where you expect some maybe refractory or recalcitrant edema, they already have a lot of edema, and you expect that edema to get worse and possibly cause a neurological deficit. Do you have some kind of a cocktail that you use to see if you can reduce that? Do you put them on a higher dose of steroids few days perioperatively, or use? I'm guessing you probably don't want to use a lot of mannitol during surgery because of the shift.
Right. So I don't use mannitol, and I don't use any diuretics during surgery.
Right.
I do start them on steroids several days before surgery, usually just a very low dose, Decadron 2 milligrams twice a day, starting about 3 days before surgery. I don't know if that's really necessary or not. It's just something I should do for all patients, even like craniotomy patients. And then they get a 10 milligram bolus at the beginning of the case. And then after surgery, I'll generally do 4 milligrams every 6 hours for 24 hours. And then based on the size of the lesion, which is kind of gestalty, I'll then do a weaning schedule after that. Early on in our experience, like for our first 50 cases or so, I had patients on 4Q6 for 2 weeks and then getting another MRI and then weaning after that. And the patients absolutely hated it. I think even though that's, so it's a fairly high dose of steroid. And I think because of the sort of less invasive nature of the procedure, the patients really feel the steroids. As opposed to a craniotomy where they're just kind of feeling lousy, generally speaking, and they don't really notice the steroids so much. Because like if you're doing a craniotomy for a newly diagnosed glioblastoma, they're going to end up being on steroids for roughly 3 months because they're going to be on steroids all the way through radiation. But I think because they're going through so much, they don't actually realize how much of their side effects are actually coming from steroids rather than just sort of routine healing from the surgery or the radiation. In contrast, when you're doing a laser ablation, they heal up so quickly from the surgery. What they feel is the steroids. And so over time, what I've done is I've actually gotten quite aggressive about weaning the Decadron off. And so for instance, something like this, if I were treating it now, I would probably try to get them off steroids within a week.
Yeah. All right.
So there have been a bunch of case series over the years looking at treatment of glioblastoma using LIT. And so they're all, as you can see with this list, this comes from a review paper that we wrote a couple of years ago, about 2 years ago, that, the case series are all pretty small and they're all retrospective. And so it's really, you can't really say anything conclusive based off of these studies. However, we did take our own patients. And so, I think, so, and Akhil can attest to this, but, we've always been quite aggressive about treating patients with recurrent glioblastoma. Our program is a surgically minded program. And there is data that suggests that the more surgeries that patients get, the longer they live. And that we don't really know. That, again, that's retrospective in nature. And so we don't know if that's like a treatment bias type picture. But it does seem like that the more treatments the patients undergo, the longer they tend to live. Now, that's kind of a chicken and egg kind of thing. Do they live longer so they can get more treatments? Or do they live longer because they got more treatments? Nonetheless, so what we did is we took in the sort of laser ablation era, which started in 2013 for us, we looked at all of our patients with GBMs. And then we looked at patients with first-time recurrences of lobar glioblastomas. So these are patients who are potentially the most amenable to laser ablation therapy, but who are also surgical candidates because it's a relatively superficial lesion. And in that cohort, we actually had a roughly equal split of patients who were treated with open resection and patients who were treated with LIT. 23 in the patients with surgery, and then 17 with LIT. We did get a variety of sort of complications. A lot of them having to deal with with bleeding or edema, but most of which did resolve. And what we saw actually was that the patients did roughly equal in terms of survival and progression-free survival. So we took the patients with lobar lesions less than 20 cc's because those are the patients who are most amenable to laser ablation. So truly, these are patients that have clinical equipoise between lit and open resection. Like if it's over 20 cc's, they're probably not a suitable candidate for lit. And in this case, what we saw was that that progression-free survival and overall survival was actually the same, or there was not a non-significant difference between the two. However, if we look at, for instance, overall survival, progression-free survival, you see that there's a tail here of the patients who had open surgery. And when we looked at these patients, what these patients had was they had a supramaximal resection. And so based on this data, if you have a lesion that is ablatable, but perhaps one that is not amenable to a supramaximal resection, then the survival is going to be very similar comparing lit and an open resection. However, if you have a large tumor greater than 20 cc's, that is still a surgical tumor, like an open resection tumor. And then if you can do a supramarginal resection, even for a small tumor, that is something that should be strongly considered, because again, that's where we tend to see these really excellent survivals compared to sort of the ones where you only get a gross total resection or ablation of the contrast enhancing lesion. So that, I mean, for us, that's really been a paradigm shift for the way we treat patients. For us at Henry Ford, for these first-time recurrent glioblastomas, especially from our neuro-oncologist view, because they see the patients post-op, they really do like laser ablation as a treatment for these patients, because they do get better so much more quickly. They can get back on chemotherapy quite quickly. At some centers, they don't even actually hold chemotherapy for these laser ablations, depending on the chemotherapy. They can generally start radiation pretty soon, although there is a problem where you're sort of combining edema on top of edema. And but on the other hand, if they are clinical trial candidates that requires resection, we would still favor resection in those cases. Also, for large tumors or tumors where you can really be aggressive with a resection, those are still the ones that we tend to favor for resection. So in the US,
a couple of questions for that. So the study that from the Henry Ford data, I'm guessing this split would probably close down or even go in the favor of laser ablation if you included deeper lesions as well, right? Because this is just mostly lobar disease, right? So I remember like operating with you for these lobar recurrences that you would just do this like en bloc, beautiful resections, and you know, almost at that time, even I don't think we were talking about supramaximal resection when I was a resident, and now even at that time you would go like you have a good 0.5 to a centimeter margin if you could afford it. So you know, so it's understandably that the difference between laser and surgery is not that great, but I'm guessing if you involve the thalamic lesions that you showed, I'm guessing the difference is going to be probably shifted in the other way, where you might have better progression-free survival with laser.
Well, so I think, yeah, so I think there's a couple of caveats to that. One is that there is data from the Lantern group. So it's a group of Monteris sites where they looked at stereotype. So this is not recurrence data, but this is newly diagnosed work. But they looked at laser ablation upfront as the upfront treatment for deep-seated lesions. So like thalamic, basal ganglia, patients who are not typically thought to be amenable to an open resection. And so they had it's kind of a funny cohort where they took 3 laser ablation sites and compared it to 2 sites where they were not doing laser ablations, they were doing stereotactic biopsy alone. And then all patients underwent Stroop therapy afterwards. And so it's a little funny because you're talking about different institutions that are doing different treatments. But in that data set, overall, which is, I'm kind of arguing against myself right now, but they actually did not see a difference in overall survival or progression-free survival. And in fact, the laser ablation group did slightly worse than the biopsy alone. However, for those patients who got a gross total ablation of the contrast enhancing lesions, those patients did better. And so that has certainly colored my thinking about whether, when I'm going to offer these treatments to these patients with deep-seated lesions, because if I think that I'm just going to do like, you know, a 60% ablation or 70% ablation, then that's probably not any better than just doing a biopsy or nothing. But on the other hand, if it's a lesion that the patient's in neurologically good condition, and I can get what I think is a gross total ablation, those patients will tend to, they would tend to derive a benefit from the treatment. So I don't know that there's any data looking at the recurrent setting for that particular setting. So the current NCCN guidelines, so this is guidelines that are put out in the US about all treatments of all types of cancers, but in the most recent revisions for brain tumor, for CNS tumors, laser ablation actually has become part of the NCCN guidelines in the treatment of both recurrent metastases and recurrent glioblastoma. So it's actually gotten quite a foothold in the United States. So for us, where does LIT fit in? So for us, I mean, basically location almost doesn't matter. Like if the patient is in neurologically good shape, you can typically do an ablation without incurring any permanent new neurological deficits, as long as you sort of stay close to that contrast enhancing margin. Still, because we like to get our patients on clinical trials, if they're a clinical trial candidate and LIT is not a part of that, then we would usually favor the clinical trial, because at the end of the day, a cytoreductive procedure is only so good for a recurrent GBM. But these are all cases that were treated with laser ablation, and in particular, all the patients in the bottom row, these are all deep-seated tumors that would be difficult or perhaps impossible to resect, especially in the case of recurrent glioblastoma, where you're talking about limited life expectancy, so you don't want to hurt these patients. So this is actually, so in the last couple of years, we've actually really sort of been pushing the needle, or pushing the envelope, sorry, in terms of what we can treat with laser ablation. So these are some of the other, so these are cases that actually are patients that I've been watching for a number of years. This patient on the left had a left insular mass, and she was unwilling to go any kind of surgery for it. She wouldn't even let us do a biopsy. And at least in my hands, doing a resection of a dominant-sided insular lesion is going to be pretty high risk. And so for a young woman, she was only in her mid-20s, for her, that was an unacceptable risk, the risk of incurring a permanent neurological deficit. Now, if you're Fred Lang or Yastergill or Mitch Berger, maybe it's a different calculation, but at least for her, and I actually offered her to send her away to other centers, but in the end, we watched this for about 2 years prior to treatment. This is another similar case, not involving the insula, but involving the anterior perforated substance. So as I look at this lesion, it's only about 50% resectable. Like, I think this part anteriorly is resectable, but the part back here is not, because of the risk of causing perforator stroke to the basal ganglia. And so this is another patient, and we do have a handful of patients that say, if when I started 12 years ago as staff, like we watch these, and you watch them slowly get bigger and bigger. Finally, you decide to do treatment, and by then sort of cat's out of the bag. Although it always is, honest, frankly, for these types of for gliomas. These are also other patients that with deep-seated tumors, where you're worried that the ablation perhaps can harm the vessels that are passing through the tumor, going to the structures that are deep to it. So what we've done here, and then finally, this is another patient who had NF and had a tumor that was in the junction between the midbrain and thalamus, and what turned out to be an aggressive pilocytic astrocytoma. He had been through many treatments, including Avastin for years, and so not somebody that we really wanted to do surgery on, although had a tumor that really needed surgery. So again, the reason that we worry about about tumors in these locations is because of these, not only because of the sort of eloquent nature of the brain that's involved, but also because of these traversing blood vessels. And we worry about causing distal infarcts to the ablation zone because of these en passage vessels. So going back to this patient with the left insular mass, so eventually she allowed me to do a stereotactic biopsy, proved that it was a diffuse grade 2 astrocytoma, and then after much discussion, we decided to do a laser ablation. Now, the tumor actually wasn't just confined to the insula, it was actually partially in the temporal lobe as well. And so we actually did 2 rounds of ablation on her over about 8 weeks apart. And the first time using 4 fibers actually, 3 in the insula, and then 1 in the temporal lobe, and then a second round with 2 in the insula and 1 in the temporal lobe. And here's this is actually showing the second round of ablation. And then this is actually what it looks like 2.5 years post-op. And she is neurologically intact, working full-time, actually recently gave birth to a child. So it's not to say that she didn't get any deficits initially. She actually, her speech deficits, she actually got pretty significant speech deficits initially after the surgery, but those fully recovered. And so again, this is, for me, this is a very compelling example of the benefit of laser ablation. I think this was a high risk lesion to treat with an open resection, at least for me. And with laser ablation, it seems like it's been quite a bit safer. And so this is another patient with a right temporal insular mass. And based on this other patient, we offered her actually a different type of a procedure where I did a single stage or single sitting laser ablation of the insular portion of the mass, followed by a resection of the temporal portion of the mass. And so this is actually two surgeries in one. We start with a laser ablation and then go immediately to a resection. So we're ablating the part that's sort of riskier for a resection, and then we resect the safe portion. And so this is the picture that we get. So stage one, we see the ablation of the insular portion of the mass. And then stage two, same day, we're doing a resection. And what we were able to get is a gross total cytoreduction of the entire lesion. And now she's about a year out for an anaplastic astrocytoma with poor with poor genetic markers. And she's 1 year into treatment, remaining disease-free, obviously still early, but so far a pretty good result. So this is actually showing one of my disasters, actually. So this is a patient who had a thalamic cavernoma. This is actually, the patient had documented growth of the cavernoma over time and had mild hemisensory deficits. And because of the growth, this is again a patient for which an open resection would be quite risky and difficult. We decided to do a laser ablation of this. I know that for instance, again, coming from a Kiel shop at Emory, they have a good experience ablating cavernomas for epilepsy. This is a kind of a different case. The patient wasn't having seizures, but rather growth of the cavernoma with multiple bleeding episodes. And what happened to him is that he bled after the ablation. And I don't know, Kiel, you might have actually been around when this happened. But basically, I think it happened actually when we took the laser fiber out, because we didn't see any bleeding on the intraoperative MRI. He actually got almost completely hemiplegic on the right side, which since then actually almost fully recovered, but he still has this spastic hemiparesis on the right side, even though he's ambulatory and able to move his arm with good strength, 4+ strength. The spasticity has been really bothersome for him, and it's prevented him from returning to work. And so, although long-term follow-up studies have shown no recurrence of the cavernoma, he was pretty initially very devastated by the neurological injury, but still now with significant sequelae from that. This is that patient that I showed earlier with the anterior perforated substance lesion. So this one we treated with the Monterre system because I can get bigger ablations with a single fiber. And I stacked two fibers, one coming from the front to get the traveling along the anterior posterior direction this way. That's what you see here. And then one from the top to get the more the portion that was extending superiorly. And we got a good ablation initially, but I think you can see that there's some residual along here where it was kind of bowing into the interhemispheric fissure. And I think that's where this is the most recent imaging here, where we're seeing as the ablation zone is involuted, we're seeing the residual here. And I'm actually planning on, this is 2.5 years out. He's doing fine, but I'm actually planning on doing another ablation of this residual. Finally, this is another case example. So this is actually a patient who had an open biopsy done of a glioblastoma, somewhat surprising based on imaging appearance, but turned out to be a glioblastoma. And then the surgeon sent him over to me for further treatment. He was actually somewhat surprisingly neurologically intact on presentation. And so this is the key difference between this lesion and the one I showed before with the right temporal insular mass is that this is the dominant side. And so what we did for this patient is we did an awake craniotomy to resect the frontal and temporal portions of the lesion initially. And then, so here we see pictures of the temporal lobe resection, pretty aggressive here. And then on the frontal lobe side, I stayed in front of the anterior cerebral arteries so that I wouldn't wander into the anterior perforated substance. But I specifically wanted to go after, there was a contrast enhancing lesion right here that I wanted to make sure that I resected. And then after that, several days later, I I then went back in and ablated the deep portion, so the anterior peripheral substance and the insular portion of the mass. Interestingly, he was actually pretty much intact coming out of the resection. The laser ablation actually did cause some speech deficits, for which he has largely recovered, although not fully. But I think compared to what I would be able to achieve with an open resection, we were able to get much better cytoreduction for this patient. He is now about a year out with, again, somewhat surprisingly, no signs of recurrence. This is another picture actually showing the trajectories of the lesion. So this actually shows the craniotomy incision, the suture line, and then this is showing the laser ablation, the way I stacked the laser ablation fibers into the anterior perforated substance and the insula. So, so looking at our case series of this group of patients with deep-seated lesions where you're worried about stroke, we've actually treated quite a number of patients now, about 60 patients in a variety of locations, but sort of the majority of which in the insula. And for a variety of histology, although very much mostly gliomas and low-grade and high-grade gliomas. And a lot of them on the dominant, most of them on the dominant side, on the left side. And what we are seeing is that a low rate of complication. So a couple hematomas, including that patient with the thalamic carinoma. Some of the patients, an appreciable amount of patients do get a new neurological deficit after surgery, but a lot of them do recover that. But what we are seeing is that a very high percentage of the patients maintain a good KPS 80 and above after surgery, and the majority of patients were able to go home from the surgery. So what was striking to us in this case series, which we're hoping to submit soon, as soon as Adam gives the go-ahead, is that we're not seeing incidents of distal stroke and one patient with a symptomatic hemorrhage. Long-term control is still unknown because this is a relatively recent case series and also very mixed in terms of histology. Now, before I sort of open it up for questions, I just want to touch briefly on brain mets. So this is a patient with renal cell cancer who had stereotactic radiosurgery for a callosal lesion that then grew after SRS. So I did a laser ablation on it, and it showed recurrent tumor. Now, I think that actually has that's actually quite important for post-treatment. Our radiation oncologists were not enthusiastic to treat again with radiation. We had some early patients with lit combined with radiation that had pretty malignant cerebral edema, so they did not want to treat initially. But what we saw was that patient had a very significant early recurrence after laser ablation. And so then subsequently underwent a resection, and then also underwent fractionated SBRT afterwards. So I think if you're doing a laser ablation and it shows radiation necrosis, and the lesion goes away, then it truly is radiation necrosis. On the other hand, if it recurs, then you have to suspect recurrent metastatic disease, even if the biopsy shows radiation necrosis. In that setting, so this is patients with recurrent enhancement after radiosurgery. It's 59 patients, 74 lit procedures. They didn't do any biopsies. Some surgeons will argue there's no utility to doing biopsies because it actually whatever is there, you want it gone. But I think the behavior of it actually is quite important over time. So if you look at these patients, the patients who had radiation necrosis, biopsy-proven radiation necrosis, tend to remain disease-free, whereas the patients here with metastatic tumor will tend to recur at a very high rate. For me, actually, I think if we, when we look at our patients, the patients who have recurrent tumor, they have almost 100% recurrence rate after laser ablation. And then actually, so for you, the question that you had, Akil, before about steroids, or about radiation necrosis. This is from the Lantern group. This is where they looked at 57 patients who underwent lit for radiation necrosis compared to 15 who had best medical management. And they looked at these various parameters. And the patients who underwent lit were 3 times more likely to be able to be weaned off steroids after ablation compared to those who just underwent treatment with best medical therapy like steroids and Avastin and that kind of stuff. So the complication rates are comparable in terms of side effects, including seizures But what's striking here is that the patients who had lit had an 84% chance of being weaned off steroids completely, whereas only 53% of patients who had best medical management were able to be weaned off. And even though it's a small cohort, the p-value was still quite significant. And what we're also seeing is that radiological control is actually superior for the lit group, where only 3 had recurrences, compared to best medical management, where 27%. So for this group, so lit is a very also a very viable treatment for recurrent enhancement, and in particular, this in the setting for radiation necrosis, can be in most cases curative. For patients with recurrent tumor, repeat stereotactic radiosurgery should be very strongly considered, but the timing of that is very controversial and is actually the subject of a clinical trial currently. And so I think that was my last